Dr. Retta will talk about the incidental diagnosis of Chiari malformation. I would like, first of all, to thank Dr. Valentini for the opportunity.
Ok, se qualcuno può dare la mano, per cortesia, alla regia, se c'è qualcuno.
We have some technical problems. If someone can help us, or perhaps I can help you. I work with children since from 1995 to 2008. We are following 236 patients. Some of these patients were lost at follow-up. Average follow-up is 49 months. We decided to take a snapshot of the situation of patients referred to us to understand how the incidences evolved over time and to what extent this diagnosis can be incidental or not. And we have seen that in 39.8% of cases, diagnosis is incidental because generally they are submitted to test. There is no suspicion about the Chiari malformation at the beginning. We have 94 patients, 47 out of them were then operated for decompression. From 95 to 2001, for 29 we had no incidental diagnosis, and from 2002 to 2008 this happened in 70 patients. This means that it's not that there are more cases, but probably it's because we carry out more MRI tests in children, and generally MRI is done for seizures, for instance in 29 patients, and then 10 were operated. Psychomotor delay, which means many different conditions, 21 patients, and 9 were then operated. And then a large group of patients with cranial trauma that then were submitted to surgery. And in these cases, 10 patients were operated, and then fibromatosis and hormonal disorders or syndromes that require also magnetic resonance. We have seen that in the vast majority of cases, Chiari malformation is a true Chiari, and in 15 patients it was borderline. Syringomyelia was present in 15 patients, and also the flow study was carried out only in some patients and showed abnormalities in the flow. Then when we assessed these patients through an accurate anamnesis and assessed the various aspects, we identified pain symptoms with headache, worsening headache, neck pain, vertigo, gait disorders, dysphagia, and dysesthesia. We have considered as clinical criteria worsening of headache and of neck pain, meaning that the child had to change his or her habits, so not after the first visit. And syringomyelia is regarded as an expression of the Chiari malformation. Therefore, in these patients, for these patients, we have opted for decompression of the posterior fossa. We adopt bone decompression, and in this group of patients we also performed a duroplasty, at least in one child with panmedullary disorder, and then a patient with craniosynosis. Some patients were then reoperated because there was progression of disease. As to the follow-up, that is minimum 6 months, this follow-up is still limited to have more reliable data. Certainly we need to have a longer follow-up period. We lost 14 patients at follow-up, and we noticed that out of our 47 patients, 33 improved, 8 remained unchanged, and 1 worsened, the one that requires reoperation. As to operated patients, non-operated patients, 4 improved, and the other are have an unchanged clinical and radiological picture. As to the neuroradiological findings, these do not refer to all patients, and we saw that MRI in the 25 patients that were operated improved, not so much in terms of tonsils. You can better see the cisterna, and as far as syringomyelia is concerned, we noticed in 12 out of 15 patients a rather good result, but a new syringomyelia developed. Flow has generally improved. We do not have many long-term follow-up patients. Some inconsistencies developed because some patients improved clinically but didn't in terms of flow post-operatively. The open points are definitely many. We have seen a growing number of diagnoses because more MRIs were made. There are not many children without symptoms. Many of these patients had 8 to 15 millimeter herniation. As to syringomyelia, there is no consensus on whether to consider it as a Chiari symptom or not. And also, this also applies to headache and worsening headache. Another problem we have to come to terms with is what suggestion could be offered to these families, how much these children need to be controlled, and how many tests need to be made, and then we have the usual discussion about decompression. In conclusion, judging from our daily experience, what stems out is that an accurate neuroradiological diagnosis is important. Sometimes we are referred patients with this Chiari diagnosis with lower tonsils, but then it's hard to manage the situation with families. In the majority of operated patients, we realized that symptoms were present, but since these children have also other conditions, there were symptoms that might mask Chiari signs. In general, we tend not to open the dura the first step. It occurred in case of severe syringomyelia, and also symptom-free patients that we haven't operated first are still symptoms-free. We recommend serial MRI every 1 or 2 years, depending on compliance and depending how easy it is to undergo MRI. if possible, also we studied the flow. Spine MRI is performed at least once, and also during the follow-up period. And also we have started to use BAP and CAP to study these patients, even though there are not many in this group. In conclusion, we believe, however, it is important not to consider these children with incidental Chiari diagnosis as true patients until when you do not have the evidence that it is a Chiari malformation, not to end up in difficult situations to manage with the family. Thank you. Can I ask you a question? If I understand correctly, some symptoms were, let's say, attributed correctly after the radiological examinations. Among these symptoms, did you have a headache or worsening headache? So a headache that was not necessarily worsened by the Valsavra maneuver. Well, generally this was an headache worsening with fatigue or with efforts. So we first of all try to understand the degree of severity of the headache. So we ask the families or the parents to keep a sort of diary to understand whether actually children change their habits as a result of this headache, because it is hard to use these subjective symptom as a single criterion to understand whether you have opted for the right treatment. And also, if you do not understand exactly the severity of the disease, we also rely on our colleagues in study functional headache, but generally these headaches have these features. And also, one more question, if you allow me. Some of the symptoms improved, but some didn't. Which symptoms did not improve? Well, these were mostly symptoms, because in one case we had one case of numbness or paresthesia, and in another case there was a syringomyelia that had to be reoperated.
Now we will hear about mucopolysaccharidosis, the cause of derangement of the craniocervical junction. Report of an affected family.
Campello.
This contribution will be held by Dr. Campello. You have 5 minutes. 6 minutes, but after 5 minutes I will tell you only have 1 minute left. So we're going to talk about MPS. It's a group of genetic diseases where enzymatic defect is along the cascade of metabolization of glycosaminoglycans. We talked about rare diseases previously, and this is a standalone form. Of course, there are other forms. It's a recessive autosomal disorder, and its incidence is estimated at approximately 1 child in 340 or 350,000 live births. The estimated worldwide prevalence is, depending on the literature, between 1,100 and 1,500 individuals. It is a disease that has various expressions. Some cases are more aggressive and their clinical history is faster and with a little lethal catastrophic evolution, and there are more moderate cases where progression is slower, life expectancy is longer, and later diagnosis. And the family I'm going to talk about is that they came to our observation only at a later stage of life. also due to the environment this family lived in. It was a small village in the national Stelvio Park in northern Italy. There were two healthy carriers, the parents and 3 children. Only 2 of them were affected, the firstborn and thirdborn. Their clinical features were typical. We will see what the various skeletal alterations involved and cardiologic alterations are. They include low stature and carpal tunnel syndrome, which is what triggered off all the different tests that we performed. You can see the picture. This is the typical facies. This is the third-born daughter, and this is the first-born daughter. And you can see the anthropometric differences compared to the unaffected sister. These are claw-shaped hands, and these are the marker findings for these patients. Neurological disorders associated to this disease are hydrocephalus due to an anatomical alteration of the meninges, CSF flow disorders, spinal cord compression at various levels, and especially at the craniocervical junction, due to the deposition of amorphous material in capsules and entrapment of peripheral neuropathies. There is no mental retardation, which is, on the other hand, typical of other mucosaccharidosis, polysaccharidosis patients. These patients had carpal tunnel syndrome. This is a picture of the third-born daughter. This is a further detail showing a severe stenosis of the foramen magnum and the features we previously described. Another typical feature of this family is that there was no myelopathy that was found after repeated neurological examinations, nor did neurophysiological tests show it. The lack of clinical myelopathy findings and did not encourage us to perform decompression and fusion, which would have been our first choice otherwise. So we proposed ERT, enzyme replacement therapy, which has become the treatment of choice, which is indeed expensive but has proved effective both in experimental tests and in early case reports from the literature. However, the effectiveness of the long-term effectiveness of this treatment is not known, so we are awaiting small case series findings. These diseases require a multidisciplinary approach and cannot be attacked. Rather, they must be managed on a step-by-step basis by clinicians. And ERT must be used as a support systemic treatment. Thank you. Arnold Chiari 1, Cognitive Behavioral Profile Case Report. This presentation will be held by Dr. Rebbi.
Grazie.
As previously noted, the literature has reported anxiety disorders or mood disorders associated with Arnold Chiari disorder. I would like to report to you a 30-year-old patient who came to our observation due to behavioral disorders and obsessive rituals, as well as a presumed intellectual deficit. This patient had gonad hypoplasia, low height and deformed face. A neurological examination showed right pyramidal discrepancy, motor impeachment, and hypoacusia. Neuroimaging showed Arnold-Chiari 1 malformation with protrusion of the cerebellar tonsils below the foramen. Genetic examination provided just his karyotype because other findings are still being processed. This is an MR picture of the patient showing Arnold-Chiari malformation. In the history of this patient is dystocic birth, premature birth with perinatal asphyxia. During early childhood, he was admitted to hospital with a diagnosis of dystrophy and food disorders. His development profile shows a delay in development stages. His behavior profile highlighted withdrawal since childhood. His IQ level is not consistent with mental retardation. It's a borderline picture. Most of these patients, as was said this morning, are borderline. His cognitive profile showed other defects such as deficits in seriation and discrimination skills, deficit in abstraction and deduction, and deficits in visual spatial organization. Adaptation scales documented lack of independence in terms of deambulation, use of clock, and use of money. His behavioral profile reported behavioral disorders based on the aberrant behavior checklist, withdrawal, inappropriate repetitive and soliloquy-like language. It's important to note that this patient started having recurrent headache, long-lasting headaches after his 30th birthday. As a conclusion, I would like to highlight the need to rule out neurological conditions that can be associated to atypical psychiatric cases, especially in patients who have a long history of disease. Thank you for your attention. Thank you, Dr. Verri. You allowed us to gain a few minutes, as it were. Now I'm going to leave the floor to Mr. Ferrante, who will be talking about a classic Chiari malformation case report. Dr. Ferrante doesn't seem to be here. Here he is.
Buonasera, ringrazio gli organizzatori per l'invito.
Good evening. I'd like to thank the organizers for the kind invitation. The spontaneous CSF hypertension syndrome is often underdiagnosed and misdiagnosed. It was described in 1939, firstly, and then with there is a prevalence among females, an age of onset is indicated here. What are the main features? Orthostatic headache, based on the international classification of the International Headache Association. So it's a so-called standing headache. After it can develop various levels, and then thickening of the dura, and then low CSF pressure. In the ICHD 2004 classification, it's included in chapter 7, chapter 7, item 3. These are the criteria. I'd like to highlight that it says that in typical cases, lumbar puncture should be avoided. In our cases, well, we have 96 6 patients, and one of these patients is a 62-year-old with hypertension and cervical arthrosis and anti-clotting therapy because of an aorta disorder. It is acute headache improving after 2 hours. The patient undergoes physiokinesis treatment that turned out to be ineffective. Headache persists, so becomes more moderately, and then there is temporospatial disorder and myasthenia, and then the headache worsens and brain CT is performed. There's hyperdensity of the bilateral sylvian fissure, and then it is submitted to our attention, and then the patient is slow, and therefore the ESCP evacuation treatment surgery was made. Here you see the hyperintensity of the media, which is often mistaken for a subarachnoidal hemorrhage. After surgery, the patient worsens, and we have periodic breath is intubated, and then he has 2 more episodes of periodic breath, and then a gadolinium MRI was performed, and we have this evidence of this syndrome with a lowering of the brain with a pseudo and the typical symmetrical enhancement, which is typical pattern of the disease, and then the patient did not show any fistulas, and then the patient was placed in Trendelenburg position, and after 7 hours he recovered. These are the images. The lowering of the encephalon, and then a patch was made, and the patient in the Trendelenburg position is then placed in the anti-Trendelenburg position and started to become numb again. But the magnetic resonance post-patch shows that this procedure was not well made technically, because there was a small amount of blood left, and then another patch was made the day after, and the presence of air and blood was identified. The patient was well for 15 days, and then once again motor difficulties, and so a third patch was performed with fluoroscopy with 30 cc of blood that turned out to be very effective. At 30 months, the patient is symptom-free and has a normal life. Here you see that the post-patch CT highlights in the epidural space hyperintensity, and so the blood flowing from the lumbar area to the dorsal area. This is a method we adopt to assess the accuracy of the procedure. Here I have the video, but unfortunately doesn't work well. You're very late, Dr. Ferrante. In any case, you see that after 30 minutes the patient starts to complain and has this severe headache, and then after treatment the patient did well. This is the MRI before treatment and after treatment. Thank you very much, Professor Dr. Ferrante. We have to close.
Martella.
Dr. Mazzella.
Parliamo di una proposta di database, mi raccomando entro i termini.
You have 5 minutes available. I will warn you after 4 minutes. Good evening. I will talk about Chiari One Malformation and Syringomyelia online database that was developed not only for the scientific community but also to the advantage of the patients. I'd like to thank the scientific committee and Dr. Valentini, who has invited me to take part in this project. By way of introduction, I'd like to attract your attention to the fact that it is important to involve in database projects associations as well, because if we want to motivate patients for a long period of time, it is important to rely on the support of associations that are generally very motivated, and then of course the scientific community will assess the data. I know this must be based on a very constructive approach. Of course, data collection must be based on very clear-cut standards established by the ethical committees and provided for by the law. Data collection should comply with some specific recommendations. First, it has to be disseminated in the scientific community, and then it has to be disseminated in non-scientific context. A lot of attention should be paid on the quality of life, and also has to comply with the guidelines for good clinical practice and the Helsinki Convention standards. This database will enable us to improve clinical practice as well as to develop more effective treatments. Why should we then collect this data? Data are important to doctors as well as to patients, because this improves also the relationship between them. We often talk about logs and registers and databases, and we have to remember that beside all this, there is a database which acts as a sort of back end, and then the front end is the register. Here we wrote a short definition of database. The database is then a sort of archive, a sort of system that makes it possible to structurally correct data. It is important to define the data source and the document source to be able to enter the data in databases. There are general purpose databases that like the ones that are listed here. We all found them in the internet. This is Orphanet and then the CMR. And then there are specific databases about specific diseases. Very interesting because they can be an example to make one for the Chiari malformation, for instance, ORCID, RBDT, and others. And in particular, ENRDB is a European network that is very interesting to me, and that can guide us in developing our database. The name of this database is CM1 database. This is what you find in the internet for ORCID, RDBD. You have 1 more minute left. This is the European Society, and this is the Chiari malformation database that is already on in the internet. That is in this website. The database is meant to study the natural history of the disease and to make observational studies, and of course, to promote knowledge on this disease. These studies are, so what data are we looking for? Data about quality of life in accordance with what we stated today in this consensus conference, and outcome data. Data are, of course, kept anonymous and encrypted. Of course, this data is gathered by doctors and patients as well. This is an innovation, though, but this is an extremely important aspect. This database involves also follow-up data. The software is on a remote server at the University of Oriental Studies, and it is possible then to translate everything into many languages. You don't need to install anything in your computers. You can access it via the internet. You can connect different centers, and you can access from many different parts of the world. Of course, the access is customized, and there are, of course, some control systems to avoid data duplication. Also, X-ray images can be loaded to have the largest possible number of X-ray images, and all patients are given a randomly generated ID. Also, various data can be included based on the needs of clinicians. So clinicians will tell us what kind of information and data should be included. And of course, patients have to grant their authorization to enter their data, and the data, of course, will be kept confidential. This is the homepage of the database. This is the data entry sheet, and this is the window you get after you have logged in. There is an ID sheet, disease sheet, and then diagnosis information. In this table, you can include symptoms from the quantitative basis, from the quantitative standpoint, and then this sheet can include presence or absence of symptoms, and then you can upload also MRI files very easily, and of course we expect a massive participation in this project to make a reliable and helpful database. Thank you very much for your kind attention. By the way, this is our website and the email if you want to contact us. Thank you very much.